like a number of questions, and we will only have time for a few of them. But my first question is to Peter. One question here is that what would you consider to be the major benefit of adopting precision medicine in kidney health?
Well, I think reduced side effects and better effect, I would say, and less progression. There are so many multiple potential benefits of that. So I think it's hard to just choose one, but and probably if you target one of these, and it will have an impact on many different parameters.
Yeah. Do you see any specific? Is it like more applied to rare kidney diseases, or would you think that precision medicine would eventually apply to all kidney diseases, like the continuum of CKD?
Well, the chronic kidney disease is such a complex disorder. So I think if we start with the rare diseases, and then when we learn more, probably more also other types, less rare kidney diseases.
Yeah. So another question related to this would be that what are the major barriers, do you think, of adopting precision medicine in Sweden, in this country?
In Sweden, costs. It will cost. These are costly drugs. Education of nephrologists to how to use the drugs and choose the right patient. I think these are the two major obstacles, barriers.
Looking to Thomas now, what do you think are the side effects are most concerning to you with GLP-1 receptor antagonists?
So usually the question always comes for acute pancreatitis from gallbladder disease and for medullary thyroid carcinoma. And from my perspective, we have RCT-based data from 10,000s of individuals. And we don't see any signal of an increased risk for all of these thyroid cancers. In fact, due to the weight loss, we see some reduced rates for distinct obesity-associated cancers. When it comes to pancreatitis, we clearly need to acknowledge the increased overall risk in a population with type 2 diabetes and obesity. So all of these individuals have an increased risk for pancreatitis events. And when we adjust for this increased background risk, there's no signal. When we, for example, have a look on these ultra-effective tirzepatide weight loss data, where I showed you the side effects, the gastrointestinal side effects, there's absolutely no dose-dependent increase for all kind of pancreatitis risk. There's only some numbers, 1 or 2 individuals who developed pancreatitis, and this was also valid for the placebo group. So I don't believe in pancreatitis risk. I don't believe in any medullary thyroid carcinoma risk.
Okay, thank you. Yeah, that was very promising.
but this is the usual question dating back to an old rat study where they saw with exenatide, a very old GLP-1 compound, having a completely different chemical structure, some data on rat thyroid carcinoma.
Yeah, okay.
Thomas, what about depression?
Good point. I would extend this question to suicide rates, because this has always been connected to bariatric surgery. And bariatric surgery resulted in an increased suicide rate, increased alcohol addiction and drug abuse rate. And there was a recent JAMA letter stating that this is not valid for these novel, super effective incretin-based treatments. So this was just a research letter in JAMA early this year, but there does not seem to be an equivalent compared to the bariatric surgery group.
Okay. So I wanted to extend the question to Jonas. what do you think, based upon your experience from this H&D clinic, what would be the discontinuation rate, do you think, of people on GLP-1 receptor antagonists or versus SGLT2 inhibitors after, let's say, 1 or 5 years? Do you have any idea?
Well, we have no hard data on it, but the experience is that some of the patients with more severe kidney function have more side effect, particularly of the GLP-1 receptor agonists. So a few of them stop completely right away. They say, we'll never take this drug again. But most of them experience some side effect, and you can sort of titrate very slowly, and then the side effect will go away after a month or 2, and then you can try to increase the dose slowly. With the SGLT2, it's very few that get urinary tract infections that cannot be managed well if they have recurrent ones, but it's kind of rare, I would say.
One of my experiences when meeting general health practitioners are that they are often keen to discontinue SGLT2 inhibitors when they see the first dip of the EGFR. Is that also your experience?
Yeah, unfortunately, if you refer them out to the GPs, then they sort of discontinue. And as soon as they get admitted to the hospital for any kind of reason, they discontinue these ones, and as well ACE and ARB as well. And they do not put them back again. And the same with, any kind of kidney problem or increase in creatinine. And that is, at least in the heart failure population, we have hard data showing that this discontinuation is causing a much higher risk in the long term for recurrent heart failure. And I assume the same will go for the kidney failure progression.
So, Carolina, would you say that, what do you think about the gender aspects here? Are there any, is there more likely that women discontinue treatments or not? Do you have any data on that?
Basically, I can't say that, and I don't know data, but I could speculate that basically gendered environment could influence. And basically, I could say that probably women would be number one discontinuing, because you don't know, maybe there are some social economical issues depending on the family situation and economical reasons, and of course how you look at that. I think from the biological sex perspective, to adverse effects, we know that for females sometimes there are those infections, but I think they are handling. I personally believe that social economical aspects, particularly and the family relations, could influence whether they discontinue or not. I truly believe that probably the woman would do. And of course maybe minorities that we are not talking, because there are issues of understanding and getting information or communication with the doctor. So far, what I could say that.
Yeah. So more likely than gender effects than sex effects, if I would sort of understand you correctly.
Yeah.
Okay. So thank you. I think that was all that we could have time with.